important to discuss, but those are just examples. And so we welcome everybody to participate and engage. Okay, so I will start with, I guess I just moved. Okay. Gotcha. Okay. So the agenda is just a very brief overview that I'm going to give, and really it's just to set the stage for the discussion and give some examples of some of these emerging new technologies and approaches that are not yet in clinical practice, but we hope that eventually will be. And then the panel will introduce themselves, and we'll have a guided Q&A. And as I mentioned, it's a conversation between all of us, and so we welcome all questions at any point during the discussion period. Okay, so I will start with a brief overview. Really, the concept of bioengineered cells and tissues, it's a massive field of research. There's a lot of interest, and the focus is really to combine cells, biomaterials, and scaffolds in order to generate tissue or organs that would eventually be used in transplantation or to repair end-stage disease as an alternative approach to transplantation. So this includes cell-based therapeutic approaches, engineered tissues for use in transplantation, and generating artificial organs, which you heard a little bit about during the trainee presentations yesterday. So I'll start with some examples of cell-based approaches. These include CAR T-cell therapy, where T cells are extracted from patients, genetically modified so that they can find, target, and kill cancer cells. They are expanded in culture so that we have enough numbers of them to use for therapeutic purposes, and then reintroduced into the patients so that they can target the cancer and kill them. There are several clinical trials, 103 listed trials. Some are completed, some are active, some are new and recruiting. And these are some examples, but for a full list, you can always look at the clinical trial listed there with the website. Another example is islet cell transplantation. In a similar way, primary islets are isolated from donor pancreas. They're expanded in culture, re-injected in the hopes that they will produce insulin and replace the damaged cells or the non-functional cells. And while there are lots of clinical trials, there is some research up and coming where they're using stem cell derived sources, allogeneic sources as alternative approaches. These are not yet in the clinic, but are up and coming as well. And then we have the example of engineered tissues for transplantation. And a good example are cardiac patches, where cells are combined with biomaterials. They can be synthetic biomaterials, they can be natural polymers, they can be decellularized matrix-based materials, and they are used on their own in combination with cells or enhanced or improved for better function using active biomolecules, such as growth factors that would enhance, for example, blood vessel formation. And then finally, I'll just touch on artificial organs. We heard a lot about this yesterday from some of our trainees, and I'll just show you, so this is a video of a decellularized lobe of a lung. And this is just to show feasibility. So obviously there's no clinical trials, but just to say that this is a pig lung that has been decellularized. So I'll go back. Can I go back? How do I go back? There we go. So this has been decellularized, and here we're just looking at the surgical approach and whether it's feasible to attach a pig lung to have the surgical approach, so that to see if can we do this actually in terms of surgery, and it is. And I'll reiterate that this approach is really, you harvest cadaveric lungs or lungs derived from pigs, and this applies to other organ systems as well, such as liver, kidney. You remove all of the cells using a detergent-based method and remove all of the cells, and what is left behind is really just the matrix and the structural proteins, which should be non-immunogenic. And you replace this matrix and you replenish it with cells that are derived from the recipient, or they're derived from stem cell sources that are universal and non-immunogenic, or from matched donors, and retransplant into the patient. So all of these technologies and therapies come with several challenges and optimization steps that are required. And these include, I'm not going to go through all of them, but generating the right number of cells. What's an appropriate cell number? How much of it do you need? How do we bank them? Where do we get them from? Are things going to be biocompatible? Will they induce an immune reaction? How do we fabricate some of these biomaterials? So there's a lot. And let's say all of these challenges will be addressed, and already we still have to think about safety concerns and ethical consideration, the regulatory frameworks that are necessary, community acceptance, and really then how do we implement and get them to the clinic? And so today, the focus is to have a discussion together around some of these concepts. And I've summarized some of the major themes that we think are important, and we'll be asking some questions to our expert panel here and get their insight on what they think will be important in terms of both feasibility and challenges. And really that's it. So let's get started. And I'll just leave this on over here so that if you can think of questions, you can come up, raise your hand, and maybe Aisha, you take over.
We're just going to ask the panelists to take 2 to 3 minutes to introduce themselves and describe their role in the context of this panel. So we could start on the far end of the table and move forward.
Do I press? Is it working? You can hear me? Great. Okay. My name is Ian Rogers. I'm a professor at the University of Toronto, and I have a research lab at Mount Sinai Hospital in Toronto. I have 6 students in my lab. 3 of them are here, Jorge, Alvin, and Marwa. You guys should wave, who do all the hard work, make me look good. And we are focused on bioengineering kidneys and pancreas for transplant. So if you have any questions about that, please ask me.
So my name is Siba Haykal. I'm a plastic and reconstructive surgeon at the UHN, and I also have a lab. We have a very busy lab with a lot of trainees, postdoc fellows, graduate students, and our focus is on tissue engineering techniques and immunology for what we call VCA. So to explain what that is, these are transplantation of non-solid organs. So things like the face, an airway, an arm, a hand, uterus, and other, other non-solid organs.
Hi, I'm Sean Delaney. I often sit on tables like this with 2 hats on. I, as a day job, work at the Alberta Transplant Institute with Lori and Patricia and the great team there. But by night and weekend, I am a 2-time transplant recipient. This is going back to 1998, so I'll be wearing the patient hat on this panel.
And an introduction from our virtual panelist.
Hi, everyone. So the obvious question is, can you hear me okay? Is everybody hear me? Yeah? Excellent. So my name is Braulio Marfil-Garza. I'm joining from Mexico, from Monterrey, Mexico. So I'm a PhD. I did my training at the University of Alberta in pancreatic islet transplantation, focusing on generating data to guide clinical decision making. But also, 50% of my time was doing basic research, and I worked with immune modulation and encapsulation strategies to make sure that we can reach that goal of having an immunosuppression-free islet transplantation. I'm mostly focusing on islet transplantation. I also take care of the medical side of pancreas transplantations. And I'm setting up right now the first pancreas and islet transplant program in Mexico. So we're building our facilities, we're training our personnel. I'm hoping to be going back to Canada to train with the Edmonton group, which have made amazing contributions to the field. I'm very lucky to keep working with them. I'm so excited and honored to be in this panel. I'm sorry that I couldn't be there in person, but I'm very excited to be here. And please feel free to ask any questions. I'm hoping that I can provide some answers or at least some insights.
Okay, wonderful. So maybe we can start by a question for Ian. So Ian, can 3D organs be made and what are the issues with manufacturing them for personal use, including production of the cells? We'll just jump right in.
That's a good question, but I'm very optimistic. My lab, we've been working on this for 10 years. And we've been making slow progress, but every hurdle we've encountered, we've managed to resolve. So I don't see anything ahead of us that's going to prevent us from not being able to bioengineer organs. What we do, and if you attended the student seminars yesterday, basically the idea is we take, in our case, a pig kidney or pancreas, we strip off the pig cells, replace it with human cells. And what's really interesting, and we have to remember here, is that the extracellular matrix, which is left when you remove the cells, is very instructive. So you can put on what we call a progenitor cell, and it will remodel that progenitor cell to make the organ. It'll organize it for you. And if you have having a little trouble understanding this, the best way to look at this is when you're young and you cut yourself or injure yourself, you repair and you have normal skin or it fixes itself. And that's because of the extracellular matrix. So we found that really the body can still do that with an adult tissue, and even the compatibility is there between, let's say, pig and human or mouse and human. It's very conserved, the ECM. So really nature is amazing and has allowed us to do this just because of the properties of organogenesis, embryology, but also the properties of wound repair. And we're just taking advantage of what's already there. I'll let some of the other panel discuss some of the other issues, but you know, one of the, besides the biology, which I just talked about, and tapping into nature, which has allowed us to do this, the other big thing we have to work on is basically having a bioreactor. You can hear me, right? Okay. It's basically having a bioreactor or a growth chamber to be able to grow the organ in. And that's been very interesting because, like with Siba and with Golnaz, we work with a lot of engineers who are basically helping us build these systems where we can actually grow organs ex vivo. And again, we have a lot of help with the transplant group, which has been doing this for years already. And just working together as a group, and we're part of a big group of 23 labs that work on this together. And I think that collaboration of experts, of all different types of experts, help us move this forward.
Great. Maybe I'll follow up with another very exciting question, which is, what do you think about modified pig organs for transplantation?
So that's actually really a question I would put out to potential end users, patients. It's really how do you feel about it? Because we've had this discussion. I mean, do we take kidneys from human kidneys that aren't useful for transplant and then decellularize those and put healthy cells on them? And the answer is it's not practical. So we have to use animal organs, and it's just really, how do you feel about having an animal organ? And I'm just going to add one quick thing to that is one of the things that we're finding out, though, is if you leave the human cells on long enough, they actually will replace the pig proteins with human proteins. So at the end of the production of making or bioengineering all these tissues, it should be 100% human by the time it goes into somebody, actually.
So I want to take a few lessons from Heather and Helene and stick to my key messages. And I kind of want to bring it back a little. So why do we even need bioengineered organs? So we need them because we don't have enough donors, right? So now we can look at how can we improve organ donation? So that is the number one way to do this. The second way is, can we potentially use xenotransplantation, which is a really big word to mean, can we use non-human organs and tissues to transplant in humans? And the big complication with that is what we call hyperacute rejection. So that's rejection that happens immediately, right away, because of antibodies that are in the circulation that just will not accept that organ. So how can we modify that in order for someone to accept those tissues? And if you've probably heard something big in the news, in the media, about a pig heart that was transplanted in a patient, and the patient survived for 60 days. So it has now been done in 2 patients, the first one being done in Maryland. And that is because of things like gene editing and removing all those barriers that would prevent hyperacute rejection. So why do we need this? Now, the third theme is, how can we transplant safely without the need for anti-rejection medication, which is another field that tissue engineering is trying to tackle? Because, for a heart or a lung or a liver or a pancreas or a kidney, it might be okay and possibly acceptable, and it is, to take anti-rejection medication. But for things like my area, which is the face, a uterus, a hand, an arm, an airway, these are thought to be non-essential organs, right? Right. So ethically, that raises a huge, there's a huge dilemma ethically. Like, is it even okay to be doing this? So this is also the third area that tissue engineered scaffolds are trying to sort of to basically improve that area of, maybe we can reduce the toxic effects of anti-rejection medication.
Sean, can we get your perspective? And I'd like to open it up to other patient partners in the group as well. Just kind of bring it back to you, as Ian mentioned.
User?
Yeah, essentially.
I like that term. We should use that more. Yeah, I think Sylvain actually opened the entire conference saying, in many ways, patients are more ready for some of those risks than I think the system is often ready to move on. So I don't think that would be a huge issue from my evening conversation partners last night. I think they would be okay with that too. But when it comes to the xenotransplant and other kinds of things, I think, especially those of us with maybe a kidney where you have dialysis as a backup, I think you want to see something closer to bioidentical, where immunosuppression is the trade-off. Like, we get to reduce or remove that, because also, as Sylvain started, many of us are living 15, 20, 30 years with transplants now, and I met 3 times through bouts of cancer. We all heard Sylvain's story. We heard Sandra's story. And so immunosuppression itself is a different disease course that many of us buy into because of our current model. And so I think a lot of us do see this field. I love hearing your explanations, Ian. But as where the science fiction is finally getting closer and closer to being reality and coming to the bedside.
Thank you. I want to open it up to other patient partners. Any comments? And I know that, Braulio, you have your hand up, so we'll come to you in just a minute. Any comments from patient partners in the audience want to speak to this?
Frank?
No, just the fact that this is super important, and I think all of these areas are very important. And so, just like you're saying, Sean, it's like, so because I happen to have, again, 2 daughters that have the same genetic mutation I do. So even what you just presented there, I'm thinking, hey, maybe that's possible. Hey, maybe that's possible. So I look for hope in all these areas. And so it's because, and I'm thinking, because this particular mutation I have, it affects the scaffolding on the right side of the heart. So it's like a muscle type disease, quite localized. So for me, I thought, well, I look at the RNA stuff and yeah, gene splicing, that's it, because we'll just go straight to the gene. We'll splice that sucker up. We're done. My daughters won't need a transplant at all. So I look for these states of nirvana, to solve my problem. And we all sort of look for these things. So, and then I thought, oh, maybe all we need is what you're talking about. Maybe we need a patch so that the signals, so the Purkinje fibers on the right side of the heart can still conduct those signals. Well, then we don't need a pacemaker for 17 years. So I look at each of these areas and it gives me great hope, and so like Sean said, I'm not worried about ethics, just get on with it, So anyway, I know it's not realistic in the system, but it's extremely important.
Thank you, Braulio.
Yeah, no, these are amazing insights from everyone. And the way I see it is we have to explore different areas. Sometimes I do hear some conversations about, what's gonna win. It's either xenotransplantation, is it stem cells, is it new technologies? I do see a lot of, competition with technologies in diabetes. And we're always, kind of seeing like which one is gonna win. And for me, the way I see it, I think each avenue has to be explored together with the patients, because some of them will have, pros and cons for the patients. Some people will prefer technology. Some people will prefer, their own stem cells. Some people will be okay with xenotransplantation. And there's a lot of research going on everywhere. But I think the solution will not be a single one for every case or every patient. There's different types of diseases. Some are chronic and degenerative. Some are autoimmune, like type 1 diabetes. So even if you generate the same tissues, we'll still have to figure out what's going to happen with the immune responses in those contexts. So I think for me, the way I see it, gene editing will be obviously preventing rejection from tissues that are not yourself, but also preventing other types of immune responses that might happen in a particular patient setting. And I think, technology is not, should not be the competition for organ transplant. There might be some machines that can replace some of the functions, and there might be some machines too that will be able to be accepted for some patient populations, some patient contexts. So I think the first comment that I would like to present is we need to think about the different options and try to get people involved in discussing every type of option. And patients, we need to know what are their preferences and all the ranges of options that we're exploring as researchers. So that would be my contribution, my first contribution.
Contribution and a great transition for our next question for Braulio. And it's more so, how do you see the integration of these up and coming regenerative medicine approaches into existing clinical practices, and what potential benefits do you see for the patient outcomes?
Yeah, so this is a very interesting question, and it was pretty much the focus of having my PhD, because specifically in islet transplantation, I'm going to be a little bit biased right now, but islet transplantation, it's a very specific procedure offered in very specific programs, very few, and the evidence is scattered all over the place. We have publications with 20 patients, 30 patients. We were lucky to have the biggest program in Canada, in Edmonton, in the world, where we got the information of the outcomes long term. So when you get to the clinic, you need to be able to provide some evidence to discuss with the patient. I think if we start pulling together evidence from different places in the world and work as a unit, that will be the best way of obtaining evidence that is helpful for the decision of the patient. And once we have this information, then we can identify areas of opportunities where we can improve. Obviously, immunosuppression is the biggest limitation for this type of therapies, transplants all over the place. So I think, the immunosuppression is a big issue. So to integrate this would open a lot of doors for many different types of patients that could benefit from cell replacement therapies, organ transplantation. And I think the barrier would be for us to generate useful and translatable information for the patients to make a decision. Sometimes I feel like we are talking about numbers, we're talking about a specific outcome, immunosuppression, control, glycemic control, but we don't discuss or we don't research enough what is the impact on the patient's lives overall, not just their numbers. I do see it a lot with diabetes, and we worry about hemoglobin A1C, we worry about renal function, we worry about hypoglycemia and the numbers of that. But I think the experience of the patient, the quality of life, the fears, all of the expectations. Sometimes we don't have the answers to know what's going to happen in a few years, and I think as a field we need to get together and try to build networks that integrate a lot of patients into specific research studies that where we can get the data that's going to be helpful to discuss with the patients. So I think that would be my comment for this question.
I want to add that I don't think we have a lot of the technology that currently works, right? So I don't think we can, answer that question. Other than maybe CAR T cells, if you look at the clinical trials in this field, there are very few. There are maybe some, cases here and there, but we don't know the long-term effects, right? So I think a barrier is it's also not a one-size-fits-all, right? So, we looked at all these different possible technologies that are available, and some of them can be a solution depending on what disease, right? So I think we have to remember that we can utilize all of them to different effects. And the barriers, I think that was your question related to what is the barrier to bringing it into the clinic. I really think that a lot of the preclinical stuff is just not there yet.
So I'm going to build on that, but also invite Siba, your perspective from a surgeon's perspective, and just looking at it in terms of the future. What kind of opportunities or challenges do you foresee integrating this engineered tissues or cells?
So what are the opportunities? I think the opportunities are that you can imagine that we would have personalized medicine. So, and that means personalized organs and tissues available for everyone, potentially, as soon as they're born, right? Where we could have, an option, to even find out ahead of time what are the possible susceptibilities. So other than depending on our, genetic background, the things that we cannot predict are things like trauma and our environment and what could possibly happen. But our ideal world is that we have what we call an off-the-shelf organ or tissue available for each individual, and we potentially have a bank of cells available that are patients' own cells and tissues available that we can use for that patient.
So I'd like to just add to that. I agree. So I've been involved with umbilical cord blood banking and the whole banking field. And one of the things we looked at is making stem cells for people and having them banked. So when we talk about personalized medicine, there's a technology called induced pluripotent stem cells. Dr. Yamanaka wrote a paper in 2006 and won a Nobel Prize for this work in 2012. And we've made about 30 plus lines in my lab. It's very easy to do. Basically, we can collect blood or urine, even from people in the room, hair follicles, and we can make you a stem cell line that would potentially make any organ or tissue in your body. And one of the issues is how long does it take? So I've had my students, catalog their time. So if someone said, I need a kidney, how long will it take us to make them a line and then make them a kidney? And we figured we could do it in 6 months, to do the whole thing in 6 months, but 6 months can be forever in some cases, and we understand that. So one of the things is, do you pre-make lines for people so they're stored, so when they need it, we've saved the 3 months of making the line. And everybody agrees we should do that, but it really boils down to it's really expensive. And right now, because we can make, for example, lines very easily from umbilical cord blood, so they're already banked, and the idea is, should we convert them all to these iPS cells where they can then make every tissue in the body? And it just wasn't cost effective. So that's something else we do need to keep in mind. There's great ideas, but it's funding them is going to be difficult.
Braulio?
Yeah, and this approach is I think, you know, we want to have that. We want to have that particular therapy for that particular patient in the particular setting, with the particular preferences of the patient. But I do think, like, and you know, I just thinking about the barriers and all of that again, I do think that overall, and I'm seeing that now as I came back to a country where these therapies are not developed and we're struggling with funding and, you know, different things. I do wonder, and I would like to see, you know, open data from other types of research, other studies, because that is something that we need to choose what to do and what not to do in our research studies. Sometimes, and there's an experience also during my times at PhD, we focus on getting, you know, the program, the project going on, and sometimes we publish something very interesting data and very positive data, but there's a lot of background data that we don't know anything about, and that could be really helpful for other research groups. We have therapies being very effective in type 1 diabetes. We have stem cells that are, you know, getting people off insulin and everything. But all of the background data, it's not well known. And I would say that, and this is more like a political statement, I think we need to open science. We need to open the conversations, the data, to guide all of the things that we're doing, because sometimes we're shooting things in the dark and we don't know. Some people have tried it, that didn't work, and that is just a waste of time, money from institutions that be funding research. And I think that's one of the barriers to coming back to the original question. I'm so sorry to go back to that one. But one of the barriers that is preventing cell therapies and organ transplantation, regenerative medicine, go to the clinic in a more efficient and safer way.
And that really brings us to, you know, one of the things that we started off with, which was the importance of communication. And so I'll ask you, Sean, you know, how do you think this interdisciplinary collaboration and communication amongst the different stakeholders, how do you think that will help? And how do you think we can start to do that? Like, from your perspective, both as a transplant recipient, but also as an advocate for transplantation research.
I'm just looking at my panel mates here, and we have already a very diverse group of people using very different ends of this research. So I think groups like CDTRP and the local research foundations and things like that have that potential to pull these groups together, because a conversation exactly like this one is probably going to have a whole lot of hallway conversation about potential collaboration. So I think continuing these kind of conversations and possibly dedicating an entire fora to building a Canadian network in stem cell and regenerative medicine.
Ian, from your perspective, how do you think, you know, what would be some valuable avenues for you to be able to communicate your research to the community, to patient partners, to organizations?
That's a great question. So just taking a bit from my experience working with umbilical cord blood banks, you know, for 20 years and trying to get that technology, that information disseminated to the public, we gave a lot of public talks. So my hospital, Mount Sinai, would sponsor public talks. U of T sponsored talks that were open to the public. They'd hold them on Saturdays. COVID kind of killed all of that, and I think we need to get that back again. But I think just simply like organizations just having talks that are, you know, in the newspaper, advertised in the newspaper, saying come Saturday afternoon to such and such an auditorium at your university. I gave a talk, I think it was in Edmonton a few years ago, and they just held it in the foyer, and there was like 400 people, and most of them were just patients and walking around, even though it was supposed to be rounds. And it was a brilliant idea of just opening it to everybody. I think that's key. Try to keep it informal and spontaneous, but not. I mean, this is great here, but again, this is still restricted to people who are part of CDTRP. I think we just need to open the forum up to everybody.
I just want to add just very briefly that over the past couple of days, I've had several conversations about better communication and how to better understand what we each do. And I was thinking for my trainees and for myself, it's such a motivating experience to be here and learn the perspective of patient partners. And I think that would really benefit the research community just to get their stories, really keep in mind what's the overall goal for doing all of this, so that when we get stuck in a particular experiment that's going wrong or we're frustrated with data, just having that big picture and knowing that your work, even though not now, but in the future, could really have an impact on someone's life. I think that's really, really powerful in terms of motivation. And so what I was thinking was it would be great to have local patient partners just come visit the lab, share their stories, have trainees give a very clear sort of layman description of what are we working on, what are we doing, and getting their perspective. And I'd like to offer that opportunity to anyone here that's interested. And I'm sure I speak for pretty much everyone doing research and science that we'd be welcome to have these discussions and share and learn from the community, so that we can better tailor our approaches and really think about some things that we perhaps hadn't thought about before that would be important. Braulio, you had a comment. Go ahead.
Yeah, just to compliment on that amazing idea of having patients coming to the lab. We did have many patients and patient partners coming to the lab, but I think it works the other way around too. There's many clinical translational programs and research programs overall that have the students, even the basic researchers, have to go to the clinics at some point and meet the patients that would benefit from their research. They have to go to the clinic. They have to talk to the clinicians too, as the clinicians have to talk to the basic research. Because at the end, like you said, that is the compass that guides you through the tough times where you're struggling with an experiment, where you're struggling with getting some data, figured out. Going into the clinic where the patient is, and the patient is concerned, and the patient is having the conversations with the clinician. That would help a lot of basic research and experimental research students to get that compass. So I would definitely try to promote that in the institution at the institutional level.
Thank you. So I just want to pause and make sure that there's enough opportunity to get some questions from the audience. So please feel free to ask any questions that you may have.
It's somebody who's in traffic.
She's the fastest delivery person in this room by far. I'm a pediatrician, transplant specialist, and I'll start with the statement of I don't think anyone would think it's ethical to exclude 30% of the population from clinical trials, in particular if they're in the highest risk group for adverse outcomes. And so with that in mind, how have you been engaging with the pediatric community, with pediatric transplant specialists, with pediatric researchers, and how will you be designing your clinical trials so that they include children at the very outset, not as an afterthought after all the adult trials are finished?
I can comment on the VCA perspective, I guess. So about 10-15 years ago, we actually published a book chapter about vascularized composite allotransplantation, or VCA, in the pediatric population. And we talked about very important themes in VCA, which are related to ethically, like consent, right? And sometimes some children cannot consent. And we talked about what would happen to the organs or the tissue as a child grows. So in VCA in particular, if you're doing a hand or a limb, will that limb actually grow with time? With the face, very similar. And also the effects of immunosuppression long-term, starting with the patient population. So we are very particular, and we are very focused on including a pediatric population in our studies. And I just came back from an international VCA conference. There have been pediatric VCA transplants that have been performed worldwide. They are less common for the reasons that I just discussed, but also they've only been done for kids who also require solid organs at the same time, because that is the only way that we can potentially justify giving them long-term immunosuppression. But those are very important themes, because we agree with you. I don't think we can not include 30% of the population. In the lab, however, I think what's an important idea is that to also remember that a lot of the work that we're doing, and I think there was a question that that came up yesterday during one of the trainee talks about, does this organ grow? Does this tissue engineered organ grow? I think Bill got that question. And I think it's important to really start looking at those themes, cells and the aging of the cells, the aging of the scaffolds, what is required in order to make sure that those organs will remain long-term. So I think an important model is to also, bring that to into the lab, in order to make sure that this could also be applicable to the pediatric population.
I would just add that with kidney transplant, for example, some people don't know that we put adult kidneys on the children. We put adult kidneys on the children all the time. So it's not a question. We may actually be able to do better with these technologies, but that shouldn't be a limitation for us to go ahead, because we're already dealing with a less than ideal situation. And so this will only be value added to what we currently have. Thank you.
Just a quick add to that, in terms of lung, and nothing is ready for the clinic, but the size of the pig, which is another question that came up during Bill's talk, right now, that is the pediatric size. So it is much easier to repopulate and to regenerate these tissues and in smaller systems. And so one of the groups they're looking at is the pediatric population and whether it would be feasible. I think Braulio, I know there's questions in the audience. I just wanted to make sure, Braulio, did you want to have a chance to give your input? And I know, Sean, you also had a comment.
Yeah, for sure. Yeah. First of all, there was a question about removing anti-rejections with increased because of the increased risk of cancer, right? So definitely, there's a lot of studies. Modulation of the immune system via tailored immunosuppression and tailored levels of immunosuppression, which that definitely decreases the risk of having adverse effects from the immunosuppression. Cell therapies that go together with the organ transplantation, or even the cell replacement therapies like Tregs that could decrease the levels of immunosuppression and give you a more nuanced immunosuppression. So those things, and naturally personalized medicine and cellular encapsulation, for example, for us in the field, there's a lot of studies with cellular encapsulation to get rid of the immunosuppression completely. So those are the things. I do think that there's another comment about forward thinking. I do think that the bioengineering, especially for cell replacement therapies like islet or stem cell derived cell replacement therapies, I do think that bioengineering, having a bioengineer that works with biomaterials and chemistry and everything, that's also an important part of the component of the team that's working on getting cell therapies into the clinic, especially with stem cells that may have a risk of transforming into other tissues that are not the tissues that are intended to be. So I think those are the comments that were there, and definitely science stays for the public. That's a great idea, and I fully support that. Yeah.
I think there were some questions. Did you?
Demetra.
Okay.
Would you like to go ahead?
Sure. Yeah, two points. The first one, if we're a little bit tongue in cheek, but if we're able to customize and grow an organ that is somewhat identical to me, I don't want a 52-year-old kidney. I want one that looks like a 16-year-old. So I would like a pediatric, an older, healthy pediatric. The other side that the slightly different topic is it's interesting that we went straight from a communications and messaging session just before lunch to this one now for someone who was transplanted the first time in the 90s. And Time Magazine in 1999 was talking about the promise of stem cell therapies, the ability to grow organs and all those kinds of things. And I think there is an imperative whenever we're doing these kinds of messaging for patients, because we're now 25 years past, to know how close are we to the bedside. So I get really excited in these conversations, but I don't have a sense, Ian, and others, are we 6 months or 6 years or another 25? Because like there has been messaging for many years about the promise of xenotransplant, and it's come and gone and things like that. But I think there's always the need to provide the realism side of things as well. No, we are still in the laboratory. No, it's not ready for clinical trials. We're many months or even years away. It's just a messaging for someone who's been watching this for 25 years.
Yeah, so I'll comment on that. I think, you bring up a good point about the Time Magazine. That was when embryonic stem cells were out, and there are all the ethical and moral issues of using them, and they're super inefficient to make ESL lines. Actually, it's really difficult. So I think the change with Dr. Yamanaka and IPS cells changed everything. It's like the light bulb and sliced bread. It just makes things more realistic. As I said, it's I get first year students coming in and first thing I do is say, hey, make an IPS cell line, because it's easy to do. It's just groundbreaking technology. And then you couple that with CRISPR and you talk about genetic, being able to alter genes. Those two powerful techniques are, in the last few years, or the last decade, have really moved things forward. And along those lines, I think, and we've talked about this about, winners and losers and what technology to come first. I think we have to do everything, as you have no idea what's going to come out of the work you do. I think, as people have pointed out, different disease, different solution. And the analogy or the example I always use for people in my lab is that of SpaceX. SpaceX, their goal is to put someone on Mars. They haven't even gotten close to Mars, but all the technology they've been developing has been very useful for a number of different things in the space field. And that's how I look at it. Our goal is to make a kidney for somebody for transplant. But I've talked to people who are making mechanical kidneys and are interested in the types of cells we're producing to basically combine cells with metal type of thing, or other issues that come up. So as long as we push and work forward, I have no idea what's going to happen between now and 5 years from now. But I do know there's going to be a lot of really interesting technology that may take us somewhere where we never thought we would go. And I think that's important to keep in mind. So I can't say 5 years from now we'll have a kidney ready to go. I mean, my students are working hard, and we would like to do that, but I just can't say that yet.
Can I just put a plug in on that one as well? For anybody who missed the 5 trainee sessions yesterday, no offense to all other presenters, but that was probably the most exciting section of the meeting so far. Just seeing what the next generation and their curiosity is driving right now. So thank you to Aisha and all your counterparts. That was fantastic.
Just want to add that, progress may appear slow, but 25 years is actually a short period of time in science. And we have come a long way in that 25 years. But the other issue is kind of like what we've learned about embryonic stem cells. We're also learning about induced pluripotent stem cells, is that they're not all safe to use, right? So, and that's why, but for some things, I think we might be 5 years away. I actually do think, and I said that a year ago, that for tracheal transplant, we are 5 years away from doing this.
We have an audience question.
Clearly needs more than a PhD to turn it on to an on. First of all, Braulio, great to see you. It's Esme from Edmonton. We miss you. Come back. So one of the questions that I always get when I talk about my work, histocompatibility and, looking at immune tolerance is, and bioengineering is like, well, why are we not doing it right now? And, people read the news, they see pig hearts, pig kidneys being transplanted and asking me if, 5 years from now, I will be out of a job. But I think the message that is often not really well conveyed is that our immune system is really, really smart. It isn't fooled very easily. And I think that that's often a message that is not well conveyed when it's out in the media there. It's all this great advertisement. People think, like, oh, this is great. 5 years from now, everybody walks around with a pig heart or a pig kidney. Our immune system is so smart. It doesn't, how many pills do you have to take to suppress it? And then it still finds ways to reject that because that's how it's trained. That's the default of our immune system. So I think that that's one of the messages that also needs to be really well conveyed in media, that it's not that easy. And the other thing is, we're talking about rejection. So what kind of rejection are we thinking about? And what does histocompatibility, what role does that play in this all, right? As you mentioned, like the pig proteins, they are replaced by human proteins, but how are we gonna monitor for that? Because if there's a pig peptide presented to a human T cell, that might still cause into an immune response, right? So I'm just gonna do a little bit of self-promoting here. Coming from a histocompatibility lab, having histocompatibility labs involved in this research early on might be helpful as well, because if it in the end comes to a clinic, then it's the histocompatibility lab that at some point has to do some sort of a test to figure out if there's rejection, whether it is to this whatever bioengineered organ it is, and whether it's a major histocompatibility or minor, such as small self-peptides or pig peptides or something like that. Just something to kind of keep in mind, because we often see all these wonderful work, and then there's not that component where in the end, if it does get into the clinic, where's the testing being done? And are these people involved in the development of this?
Yeah, I 100% agree with you. I think if you are building a bioengineering group, you need to have an immunologist that is on board and is able, the immune system is adaptable, right? So regardless of what you change and you modify, it will find a way. So absolutely, we need somebody like you on our team to be like, okay, well, this is what else we need to do, or how do we counteract that? And absolutely, we need to hear that perspective.
Yeah, and I need to add to that. There's not enough hours in the day to explain everything, but we can't look at it as absolutes or black and white. So even the group that modified a pig organ, not in the way we're doing it, but they modified those proteins that trigger hyperimmune response. They even said in their paper that their goal was, it's a temporary fix to have these organs put into somebody for a limited amount of time until a better organ is available for that person. And I think we have to keep that in mind. No, they weren't saying we're going to put this into somebody for life right now. They know they need more work to do, but it doesn't mean we can't use that organ as long as we understand the limitations. And from the work we do, again, I talked about the turnover that we look at it as that, yes, maybe we transplant our bioengineered organ into somebody and they are on immunosuppression, but knowing there's this turnover, it may be a matter of months, maybe a year, and then they don't need to be on it anymore. And that's where the technology looks. So again, we're not saying that we're going to put this in and everything's going to be wonderful, but it's going to be better than what's available now. And it's these incremental improvements to make someone's life better and the quality of life better. And down the road, hopefully one of my students will have their own lab and they will come up with the holy grail. But on the way there, I think we can still have technology that will help.
Braulio, we have 1 minute I'll just say on behalf of Aisha and I, thank you for everybody for your participation, for your questions to the panelists, and Braulio, perhaps you can finish off the session with your comment.
Yeah, thank you again. It was a pleasure and honor. I really miss you too, Esme and the team at Edmonton. I'm hoping to go back soon. And I want to echo on the comment. I think we are close to having bioengineered organs, bioengineered tissues, but there's issues with the immune system and the immune response that we still need to work together to solve. So I think patient partners will be need to be in the equation every step of the way to guide us into every decision, every research road that we're doing, and always keep them in mind. So that'll be it. I have to jump to this out of the session, but it was a pleasure and an honor, and thank you so much for this conversation.